surgery.
Yes.
We're talking about sleeve, we're talking about before the bands and so on. Instead of going so much into the history, let's just concentrate on what do you think is the type of surgery suitable for the patients these days. We're talking about sleeve as a bridging surgery, or as a final surgery, or the gastric bypass. Especially when the people in our country, they have an idea that bypass surgery is a dangerous surgery. And I don't know if this is really a fair comment. What do you think?
Well, as you of course perfectly know, we have basically three types of abdominal surgery. The respiratory procedures that reduce the volume of the stomach. You have less intake and so you lose weight. On the other side, you have malabsorptive procedures, as we call BPD or the duodenal switch, or now the single anastomosis duodenal healer, the SADIS. They give no restriction or a very little amount of restriction, but you have malabsorption. And well, actually, I don't prefer this technique, this surgical approach, because malabsorption is very difficult to manage in the post-operative period. To me, the ideal solution are mixed, so named mixed procedures that are the bypass procedures. Bypass procedures combine some malabsorption with some restriction. I would say some hypoabsorption more than malabsorption. And this is important because you can have a dosage, of how much restriction or how much malabsorption you want to give to your patients. And this can be modulated by evaluating the length of the bowel loops.
That's very interesting, actually. I noticed yesterday that you are measuring the length of the bowel and then you do your surgery, although this is taking a lot of your time. Could you please explain this to us, because this is very important.
But the answer is very easy to give. You know that the 90% of the absorption of solids and liquids is in the small bowel. So by reducing the absorbing capacity, activity of the small bowel, you have the chance to give hypoabsorption or malabsorption. So before you give some bypass or exclusion of small bowel, I think that it's very important and useful to know how long is the entire small bowel. This is the answer.
Give us some examples, because for example, you had two patients. One of them, we measured the bowel was 7.5 meters, and the other one was 9 meters. The classical teaching in the school was between 5 and 6. That was a surprise to me.
Yes.
So could you please tell us, especially when you're doing it with this scan?
It has been a surprise to me too. I mean, when you study on the anatomy books in medical school, as you will reminding us, normally the small bowel is reported between 4.5, 5, up to 8, 8.5. This is the range normally. But since when I've started to measure the internal bowel, I've seen incredible things. I've seen very big people with 4.5 small bowel, or I've seen very small people, but fat people with a small bowel reaching 9 or 10 meters. So it's very variating. There's a lot of differences among the measurements in the small bowel.
And you are controlling it now with the CT scan with contrast?
Yes, as I commented yesterday, we're bringing ahead a study with the cardiologist. They first measured the small bowel according to their algorithm and with some contrast media, the oral intake of some contrast media. They try to measure the entire small bowel and give us a number. Well, we are blinded, okay, about knowing this number. Then we measure this patient, the small bowel of this patient into the OR. And at the end, we made a comparison to see if the CT scan is really reliable, because it could be a very great advantage to know before surgery how long it is the small bowel, because it allows you to give the correct length of bypass.
And why is it so important for you, Mario? Because is it because you are trying to decide where to put your anastomosis? Yes. So how much you are going to reduce?
In my opinion, if you go to bypass surgery, especially one anastomosis gastric bypass surgery, the ideal is to exclude 1/3 of small bowel from the surgeon, to bypass 1/3 of the entire small bowel from a surgeon. So in these cases, you have to know how long is a small bowel. It is 9 meters, you have to exclude 3 meters. It is 7.5 meters, you have to exclude 2.5 meters. So this is the answer. So before excluding, before bypassing, you have to know how long is a small bowel. That's all.
Roberto, hearing a lot about Saudi Arabia and the obesity in Saudi Arabia and the difficulty of obese patients. You have worked there for 15 months and you have seen so many patients in King Faisal Specialist Hospital. What is your opinion about the health system in Saudi Arabia and how is it going to develop? And do you think that obesity surgery has got a big role in sort of reducing the cost in the treatment of patients? You know, those patients are diabetic, hypertensive, they need a lot of medications, lifelong, and so on. And this medication are expensive. So what do you think?
Well, as you know better than me, this is a rapidly evolving system. So what I noticed is that because of the absence of GPs, so general practitioners, the patients are usually going to the hospital when they are really sick. And if you are considering cancers, in most of the cases you have really very few weapons for fighting this cancer. Of course, NASH has a big incidence. I don't know exactly how much is now the incidence in Saudi Arabia, but there are a lot of patients. I'm sure that if you can, with surveillance programs or some screening and medical control, you can have an idea about the population at risk. And I'm sure that with some cases when the surgery is indicated, you can improve their status, and maybe you can also avoid tubes, because as I said to you, if you have a patient with morbid obesity, metabolic syndrome, diabetes and NASH, this is a well-acknowledged risk for occurrence of hepatocellular carcinoma, and the discovery of the HCC in such patients is a drama, because many times you have huge tumors. You cannot transplant, but most likely you can also not resect because of small remnant or a bad quality of the remnant liver. So I'm sure that the surgery can help, but you have also to improve the first line of the primary care, which is fundamental.
I like your comment.
I know that you are working on this.
Yes, I like your comment actually, and this is something we raise it to our responsible people, that the presence of primary care in our country can help a lot in reducing a lot of the problems. Mary, I have noticed a couple of things in our country that the patients are suffering a lot. One is pre-surgery. Nobody is thinking how to prepare these patients. I have noticed yesterday a body mass index, huge body mass index, but the liver was small. This is actually because you have used in these patients some of the medications that reduce the size of the liver quickly before surgery. The other thing which we talked about was some of the medications that you have developed here in Italy, where you advise your patient to take to reduce the missing of vital issues in the future. Could you please give us an idea about this?
Sure. Bariatric surgery is a surgery that needs a collaboration of all sort of specialists before and after surgery. There should not be surgeons necessarily, but they must know very well physiology, anatomy, and the metabolic working of all the body. And my comment is that for the pre-op phase, for the pre-op period, it's important you give a diet that allows liver shrinkage. We are using actually a ketogenic diet that is very useful to get a liver size reduction. You've seen yesterday in my OR, the patients were 45, 47 BMI, but the liver was very affordable, I would say.
Exactly.
And this is important for the health of the patient, but even for the health of the surgeon, because it allows you to give the best results with surgery. And this is for the pre-op period. I repeat once again, use a ketogenic diet. For the post-op period, especially when you have used malabsorptive procedures or mixed procedures as bypasses procedure, it's important that you give some supplementation. When you give a BPT or a SADIS to your patient, they are going to face some reduction in the absorption in protein, lipids, sugars, and even oligoelements like vitamins. When you give a bypass to your patients, the problem is especially with oligoelements, especially vitamins and minerals. In this slide, it's important to give them a supplementation. We have a lot of specialists in this field in Italy that are dedicated to the supplementation, to prepare a right supplementation in terms of diet, in terms of drug to these patients. And well, I believe that especially following a bypass surgery, the vitamin and the oligoelement supplementation is very important. The patients routinely get a small pill, a small capsule every day in the morning, and they are okay, and they are not at risk to get any hypoabsorption or loss of vitamins or minerals.
Thank you very much. I must admit that I'm so happy to see the sunshine coming now. So it means that we can have a nice day today. Thank you very much, professors. It's a great pleasure to have you.
Our pleasure. Our pleasure.
Thanks a lot.